Good evening. It is my proud privilege on behalf of Teleophthalmology Society of India to welcome you all to our 7th session of refresher training for ophthalmologists on diagnosis and management of diabetic retinopathy. I welcome Professor Natarajan, our President, TOSI, and incoming President, Dr. Kim, and the speaker today, and my colleagues, Dr. Sabyasachi Patnaik, Dr. Sheila, and others. I welcome also all the spokes, including the dynamic Dr. Rajvinder Kaur and all group to this 7th session of diabetic retinopathy, the topic being the proliferative diabetic retinopathy, and it is a didactic and case presentation by none other than our President-elect, Dr. Kim. So as you know, this program was started on 7th July with an intention to train the ophthalmologists all over the country on basic knowledge and diagnosis and management of diabetic retinopathy. And we have already held 6 sessions so far with our elite TOSI members and the speakers of national repute. Today, the turn of our President-elect, Dr. Kim. Next slide. This is the format. Our experts being including Dr. Natarajan, Dr. Rajiv Brahman, Dr. Senthil, Dr. Sandeepak Rai, Dr. Abhishek, Dr. Ashok Nanda, and Dr. Kavita Rao. Whole TOSI team is the experts. So just before we start the program, as you know, today's topic is proliferative diabetic retinopathy, the end stage of a disease, because probably it has not been taken proper care in its early stage, which we are working hard in the prevention of diabetic retinopathy. So this just small example, this is a 37-year-old man came to us with a decreased vision for the only last 15 days. And he was found to be diabetic only 6 months back only, with a high blood sugar of 350 something. And when he came to me the 15 days back with a entire segment almost normal, a reduced gross reduction of visual acuity with a fundus picture showing proliferative diabetic retinopathy with a, I would say, high risk PDR. So similar cases are present in amongst us, and in the advanced stage of diabetic retinopathy, being a 37-year-old man having advanced proliferative diabetic retinopathy, is long life to live, and how do I manage? So these are the so many issues and challenges in front of us. So we would like to listen to more today on management of PDR by our friend Dr. Kim. Introducing Dr. Kim is the Chief Medical Officer of Aurobindo Eye Hospital, Madurai. Dr. Kim, everybody knows his household name, not only nationally, internationally, in the retina world. He began his career as a consultant in vitreoretinal services at Aurobindo Eye Hospital, Madurai, after completing his DO-DNB from the same institute, and later became the chief of the clinic. Presently, he is the director of Aurobindo's telemedicine network and IT services, and also the chief medical officer of Aurobindo Eye Hospital, Madurai. He has published several publications in peer-reviewed international journals, national journals, and state journals. And he also published a lot of 2 book chapters so far. He received his Lifetime Achievement Award at 33rd Asia Pacific Academy of Ophthalmology Congress held at Hong Kong. Best Doctor Award by Tamil Nadu, Dr. MGR Medical University at the Silver Jubilee celebration of the university. Dr. Sudha Sutaria Vitrectomy Origin Award at the Vidarbha Ophthalmology Society, Nagpur. Dr. Rustam Ranji Oration Award at the annual meeting of Andhra Pradesh Ophthalmology Society, and also Rhett Buckler Award for the best video screen at ASIR RS Film Festival held at Vancouver, Canada, and so and so. And so many other awards, there's no need to mention here. His lecture and his presentation will speak about himself more. Thanks to ECOP, again providing this platform for the 7th time. and we look forward to continue this platform another few months to few years. This is our TOSI team. Already I told or recited about the team members and our president. I request all of you here to join as a member of TOSI. Just we are waiting for the its registration document to come. Then we start the membership. So these few words, I welcome again to our TOSI session, 7th session on proliferative diabetic retinopathy. Speaker being Dr. R. Kim. So it's over to you, Dr. Kim, sir. And before that, I would say ask Dr. Sheila. So she will be moderating the session today, and Dr. Sabyasachi Patnaik to say a few words. And of course, none other than Professor Natarajan to start the address before Dr. Patnaik and Dr. Sheila will speak. So it's over to Dr. Natarajan. Dr. Natarajan, are you there? Okay, before you join, Dr. Sabyasachi Patnaik, your comments.
Thank you, sir, for this wonderful opportunity. Now we had a very excellent experience regarding discussing the diabetic retinopathy, starting from its epidemiology to management and all sorts of complications for a training purpose. So I think be successful in providing a little bit of guidelines to all our participants. So this brief statement, the comment, I request Sheila Madam to moderate and to start the program.
Looking forward to a very good lecture by Dr. Kim, sir. I think we should invite him to deliver his lecture.
Should I start?
Yes, sir.
Yes.
Yes, sir. We are eager to hear you, sir.
Thank you, sir. At the outset, I want to thank ILCO for organizing such a wonderful series of lectures on an important topic on diabetic retinopathy for practicing ophthalmologists and the postgraduates. And glad that TOSI has an opportunity to be a part of this. And I want to thank everybody for giving me this opportunity to speak about an important topic on proliferative diabetic retinopathy. I hope all of you can see my slides.
Yes,
Yes,
sir.
sir.
Yes, sir. It is visible.
So we have been repeatedly seeing how the diabetes is becoming, is an epidemic almost in many parts of the world. And I don't have to say how important it is for a country like India. So diabetes, we have been hearing, it has got both microvascular and macrovascular, and as ophthalmologists, very, very important for us to handle or understand diabetes affecting the eye, mainly due to diabetic retinopathy. So what are the different stages of diabetic retinopathy starting from the no diabetic retinopathy with time? The patients develop multiple stages. They go through a non-proliferative stage and a proliferative stage of diabetic retinopathy into an end stage where they generally tend to lose vision. So here our focus is more on only on proliferative diabetic retinopathy. We've been hearing about the other conditions earlier on. So this is by definition by the DRS group is an advanced stage of diabetic eye disease characterized by growth of newly formed retinal vessels on the retina or optic disc that extends along the retinal surface or into the vitreous cavity, which significantly increases the risk of losing the vision. So if you look at the previous data of the risk of developing proliferative diabetic retinopathy after having 15 years of diabetes, type 1 people are more likely to prone to having 25% of them would develop PDR, while type 2 is almost 16%. With the changes in the approach to management of diabetes, this is changing over a period of time. This data comes from the Wisconsin Epidemiological Study of Diabetic Retinopathy, so quite some time back. If you look at the histopathology, the three most important things that have happened, I'm repeating this because just to understand the importance of diabetic retinopathy, the changes in the blood vessels that happen, that is the basement membrane thickening, loss of pericytes which causes the support loss, and an endothelial dysfunction with capillary acellularity. This all leads to the complications that we see, typical complications that we see in diabetic retinopathy. So what is the pathogenesis of proliferative diabetic retinopathy? The hyperglycemic state and the other metabolic changes causes reduced perfusion of the retinal tissue, causing retinal ischemia or hypoxia, leading to an increase in the vascular endothelial growth factor, which results in angiogenesis. So with this increased level of these growth factors, there's a retinal angiogenesis where you have development of vascular buds, or what we call as vascular epicenters from the retinal blood vessels, as you can see in this animation, where these tissues grow over a period of time into the vitreous cavity, which attaches to the posterior lamella of the cortical vitreous. Once these fibrous tissue forms, they cause contraction, and this vitreous contraction of the friable vascular tissue leads to tractional retinal detachment if untreated. So this is the whole process in which proliferative diabetic retinopathy progresses to making people lose their vision. So here you see a picture of the vitreous causing a traction on the retina, which leads to probably a rupture of the blood vessel, sometimes tractional displacement of the macula, and tractional retinal detachment happening. This is a patient who was followed up in September 2003 when the patient presented with irma and venous bleeding. They were followed up very closely. Initially, there was later fibrous tissue appeared. This patient refused initially the laser treatment, and this very clearly shows how these irma and then subsequently all these areas of ischemia leads to these new vessel formation, leading then subsequently to a pre-retinal new vessels raising, attaching it to the vitreous, and then fibrous proliferation happening, which ultimately leads to a tractional retinal detachment in that particular area. So PDR is one of the main reasons, one of the things that are important is the presence of neovascularization is when you call PDR, with, of course, with the development of these rupture of these new vessels. As you know, these new vessels are just endothelial tubes. They do not have all the three layers of the normal blood vessels. So they rupture easily, causing vitreous or a pre-retinal hemorrhage, and subsequently because of the fibrous proliferation leading to tractional retinal detachment. So once you identify a case of proliferative diabetic retinopathy, we have been traditionally taught that fluorescein angiography is the investigation to be done in diabetic retinopathy. But today the role of FFA is very limited because it's an invasive procedure. A patient can develop anaphylactic reaction. So we minimize the use of FFA, and for obvious reasons. And it is usually indicated when you're having unexplained visual loss, like in macular ischemia. In PDR, to identify, especially in severe NPDR, we are not able to identify any new vessels, or to identify, differentiate IRMA. IRMA doesn't leak, while the new vessels would leak, as you can see in the picture on here. And then also to identify these areas of extensive capillary non-perfusion that is present in these patients, which will tell us or indicate to us that these patients need to be followed more closely than the others. Ultrasonography is another very important investigation that is done, especially in patients who are presenting with vitreous hemorrhage, where the media is not clear to visualize the retina, where you need to identify the extent and the severity of the vitreoretinal traction, especially if it is present in the macular area. Another important investigation modality is in the recent times that is available is the ultra wide field imaging, where you're able to see almost 120 to 180 degrees of retina in one single photograph. Unlike we have superimposed the 7-field ETDRS fields, where you see that you are seeing a really, in spite of taking 7 fields, you are taking a very small area of the fundus that you are visualizing. So this actually gives in one aerial view the entire retina, where you are able to identify the lesions in these, as in this case where you can find out the extension of your fibrous proliferation, the extent of new vessels, the presence of vitreous hemorrhage, and the PRP marks that are seen in this case. So more important to understand is the management of proliferative diabetic retinopathy. The gold standards, that is the systemic control of managing keeping a metabolic control, is like the blood glucose, blood pressure, and blood lipids, which we have been hearing very often, is the 3 important factors which at any stage of diabetes or diabetic retinopathy is important to be kept under control for other treatment to be more effective. Whether you're doing laser treatment, medical treatment, or surgical treatment, it is very important that the systemic control is maintained throughout the treatment period or further on also. Of course, the medical treatment, we have the anti-VEGF approaches using of intravitreal steroids, more limited to another sight-threatening condition, that is the diabetic macular edema. But it is also in use in certain conditions in proliferative disease. Of course, surgical management I will be discussing subsequently. So the early treatment of diabetic retinopathy study way back in 1970s gave us the actual reason for doing, or at least when to do. The DRS study had shown us that PRP definitely saves vision, but when to do during the course of the disease or during the course of diabetic retinopathy, when do you do a pan-retinal photocoagulation? So it was clearly seen the PRP reduces the risk of severe visual loss when laser treatment was given early, or it is deferred until the development of high-risk proliferative retinopathy. So you need to ensure that it is attained a certain stage or is indicated in a certain stage when diabetic retinopathy has reached the high-risk characteristics. So do you do early photocoagulation or do you defer photocoagulation? So in mild or moderate NPDR, you do not consider doing a pan-retinal photocoagulation. But in a case with severe NPDR, which is reaching a high-risk characteristics, you would consider doing a pan-retinal photocoagulation. So what are the high-risk proliferative changes that you would see? The ETDRS had given a standard photographs, and standard photograph 10A that I've shown here is an indicator for us to compare whether it is more than or less than .
I think connection has been lost.
It's okay, but we can't hear him. Slides are moving. Dr. Kim, we can't hear you.
Your problem.
No.
Hello, can you?
Yes, now we can hear you. Yes, please.
Oh, okay, sir. I'm hearing a echo. That's why I wanted to.
Now it's clear, very clear voice. Please continue.
Okay.
So once you decide to do the laser, there are two modes of laser that you can use. Delivery mechanism that is the most commonly used is the slit lamp delivery mechanism, where you use a mainstem lens to focus the laser into the onto the retina. And the second one is the indirect ophthalmoscopy delivery system, the LIO, laser indirect ophthalmoscope. This you would use it only for doing a pan-retinal photocoagulation and not for a grid or a focal laser treatment. The endo laser, where you deliver while doing surgery, is only limited to when you're operating, and when you're doing a vitrectomy or working inside the eye, you will be able to deliver the laser inside the eye. So the pan-retinal photocoagulation is, you usually use 200 micron spot size with the duration of 200 milliseconds. Sorry. Titrate the burn with the lowest possible power to achieve a grade 3 burn, as you can see here. With usually the distance between the two burns should be a 1 burn width apart. And very often we prefer to do it in 2 or 3 sittings, depending on the risk factors that is associated with the diabetic status of the patient. So the other modes that, as you can see, sorry. So this is a typical pan-retinal photocoagulation image, montage image of the retina, where you can see the laser spots being placed. There are fresh and old laser marks seen in these pictures. It's important to uniformly place this without skipping any areas to ensure a complete coverage with laser. The new, it's not new, it's been there for quite some time now. That is the pattern scan laser has made delivery of laser or doing pan-retinal photocoagulation much more easier for the ophthalmologist, because it gives in a single shot multiple laser marks are done. These are semi-automated system which delivers laser pulses with shorter pulse duration in a rapid predetermined spot pattern. You can choose, as you can see from this picture, a single spot, 4 spots, or multiple spots as you want it to be delivered. The benefit of this is there is less total energy, there is less scar expansion, and then so there's a less choroidal heating. But one of the the other disadvantages, very often you may need to repeat the laser if it is not adequately covered. Sometimes these patients need a multiple sitting of laser. The other one is the navigated laser system, which is a fundus camera based laser planning system, where you mark the area where you want to, in the fundus image, where you want to place the laser, so that this is mainly useful for doing over a grid or focal lasers, because this protects the area like the disc, the macula, so that even if you focus on it, the laser would not hit the macular area, and this will prevent any inadvertent damage to the macular area. So these are very expensive lasers, but these are available in the market as of today. So what are the complications of pan-retinal photocoagulation? Is the most important is the field loss, the macular edema, that patients may develop diabetic macular edema because of the overheating and the inflammation that is created by the pan-retinal photocoagulation. Sometimes patient may experience pain, and extensive laser can cause sometimes a macular epiretinal membrane, and in presence of fibrous proliferation could lead to a tractional retinal detachment, and sometimes a single sitting of PRP could often lead to a choroidal detachment or exudative retinal detachment in certain select cases. The next treatment, today PRP is the standard set of treatment, but with the advent of usage of intravitreal anti-VEGF agents, there's been a lot of interest in using these drugs to avoid the complications of pan-retinal photocoagulation. So one of unlike in diabetic macular edema, where multiple studies were done, there are only 3 select studies that gave us a clue on how to use intravitreal anti-VEGF agents in cases of proliferative diabetic retinopathy. And the most important is the protocol S of the DRCR net program from the US. This was done to determine if the visual acuity at 2 years in eyes with proliferative diabetic retinopathy that receive anti-VEGF therapy with differing pan-retinal photocoagulation is non-inferior to those in eyes that receive prompt PRP therapy. Basically, they were trying to see if just giving multiple injections of an anti-VEGF injection in these patients and not doing pan-retinal photocoagulation for some time, is it same as giving a pan-retinal photocoagulation, and how does it do at the end of 2 years? So protocol yes clearly demonstrated that the anti-VEGF agent which was used as ranibizumab is at least as effective as PRP in treating the proliferative diabetic retinopathy. Additionally, ranibizumab treated eyes were less likely to develop. This was one of the advantage, that these patients were less likely to develop diabetic macular edema, and they were less likely to require vitrectomy. While pan-retinal photocoagulation even today remains the primary treatment for PDR in many patients, anti-VEGF therapy can be considered for patients in select patients who can be followed up closely, who understand the risks and or involving the cost as well as the frequent follow-up that will be needed in these patients. Even the 5-year follow-up showed that the visual field loss, which is seen in diabetic macular, in pan-retinal photocoagulation, it was seen even in the ranibizumab group, almost approaching that of the PRP group. The mean change in the visual acuity group was similar at the age of at 5 years, and in the ranibizumab group, only few patients developed center involving diabetic macular edema and retinal detachment compared to the PRP group. But most importantly, the PRP group had very few visits, almost half the visits, half the number of injections compared to the pan-retinal, the anti-VEGF injection group, where they had to make multiple visits, 42 visits compared to 21 visits in these patients. So both groups had an incidence of vitreous hemorrhage of almost 50% during these 5 years. And these results suggest that both PRP and ranibizumab injections are good for treatment of PDR with similar results. Another trial using Aflibercept was done, the Clarity trial, which again showed that the intravitreal Aflibercept or the Eylea is an as effective alternative treatment option for PDR in the first year, and similar results were observed in the second year too. Another study which compared the Proteus study done in the UK compared the efficacy of ranibizumab intravitreal injection plus pan-retinal photocoagulation compared to pan-retinal photocoagulation alone in the regression of neovascularization area in the subjects with high risk. They took only high risk PDR over a 12-month period, and they did found that this combination was a little bit more effective than monotherapy in high risk patients over the 12 months. But as of today, in our economic situation, PRP still remains the treatment of choice in all the cases of pan-retinal photocoagulation. In all the cases of proliferative diabetic retinopathy. With once this stage is crossed where the patient has developed vitreous hemorrhage or developing a tractional detachment, the surgery is the only treatment of choice. So with time, the PRP has evolved. Conventionally, it was meant that if you had a non-clearing vitreous hemorrhage for a period of 3 to 6 months, you would consider doing a vitrectomy or a tractional retinal detachment involving the macula, or if there is a combined tractional and rheumatogenic retinal detachment. So we were conventionally taught to wait for 3 months. If there is no evidence of clearing, then you would operate earlier. If associated with, or if it is associated with the tractional detachment, you would even consider earlier, or if it is one-eyed patient, you would consider doing a vitrectomy. But today, with the advent of newer equipments and instrumentation, we are able to operate on even patients with very good vision with certain indications such as severe fibrovascular proliferation, dense premacular hemorrhage, dense vitreous hemorrhage in the presence of rubeosis, or patients having ghost cell glaucoma, even patients with vitreomacular traction, and in vitreopapillary traction, you would consider doing vitrectomy in these patients. Sometimes you have parafoveal tractional detachments. Do they all progress to macular detachment? Not at all. Some of them do not progress and they remain to be stable. But if you have a documented progression of diabetic tractional retinal detachment, even if it is present elsewhere in the extramacular area, and if you notice progression, these patients who are followed closely, then you should consider doing early vitrectomy in these patients. So in all these cases, it's important to explain the prognosis to the patient. We have to decide on the surgery versus observation. You have to consider all the other parameters, such as the systemic status of the patient, before considering the surgery for these patients. So what is the goal to do? Vitrectomy is to remove the axial opacities, relieve any anteroposterior traction that may be present or tangential traction that may be present, remove or peel membranes, affect hemostasis, and deliver laser treatment in these patients. So vitrectomy, as I said, remove the vitreous scaffold. We have been typically taught about delamination, segmentation, en bloc dissection. So what are these? Segmentation is when you have a membrane. Today we do a multiple combination of these, such as multiple islands of these membranes are cut, and then you remove them in pieces. Or delamination, where you would remove these membranes as a whole in these situations, depending on it. So today, with the improved instrumentation, we are doing a lot of combination of these procedures to remove these membranes, what we call as en bloc dissection, where you use the anteroposterior traction of the vitreous and the membranes as a support to cut these membranes and remove them in toto. So these are we also have ways how understand how these membranes are attached, or these vitreous is attached to the posterior tractional membrane. So if you find a membrane which is just touching on the, like in this case, it is easy to peel off these membranes. But if it has multiple attachments, like here, peeling off these membranes could lead to a tractional, to a retinotomy and end up with severe vitreous hemorrhage if not identified and cut into pieces. So this is where sometimes doing a bimanual surgery as here would help. With, again, as I mentioned, with the advent of all these newer instrumentations, things are becoming much easier to manage these patients very effectively. So the outcomes are much better today. The intraoperative OCT, which is also available, helps to identify the membranes from the retina as you are cutting it. You're able to identify the membrane versus the retina. So you're ensuring that you don't cut the retina, but you're only cutting the fibrous membranes. So we have very good prognosis in these patients today because of the surgical modalities that are available. And again, using of preoperative anti-VEGF, many surgeons today use this because this reduces the intraoperative bleeding that happens. There is a level 1 evidence that shows there is a reduced surgical time for, also in the postoperative vitreous cavity hemorrhage is very much decreased. There's a level 2 evidence in the fact that there is a reduced number of instrument exchanges or in the severe intraoperative bleeds that you may see during this period. So very many surgeons actually today use these preoperative anti-VEGF, and some people use postoperatively also anti-VEGF injections, while to reduce these some vitreous hemorrhage in the scene postoperatively. Just to summarize, there are various treatment options for proliferative diabetic retinopathy. It's pan-retinal photocoagulation, and occasionally we can add intravitreal anti-VEGF to this. And once it reaches the surgical indication, partial vitrectomy is the choice for these patients. So it's important to be aware of this and to prevent any progression from early stages to late stages in stage. So early diagnosis or frequent follow-up in these patients and initiating prompt appropriate treatment in these patients with good metabolic control will definitely go a long way in helping these patients. And the surgical prognosis, I said, is good with a regular follow-up. So I would like to thank at this point and stop here for further discussions. Thank you, sir.
Thank you, sir, for the excellent lecture. We learned a lot about proliferative diabetic retinopathy. I have a question for you, sir. When you're doing a pan-retinal photocoagulation, sometimes you do only one sector or two sectors of the retina. Sometimes it's all 360 degrees. What decision you take to do one sector?
Usually,
or
when you have the high risk, once you have a proliferative diabetic retinopathy, it is important that there is the areas of capillary or ischemia is almost spread throughout, especially when you have neovascularization on the disc. So it is an indication to do a complete pan-retinal photocoagulation. It's very selective situations where you do a select sector for pan-retinal photocoagulation, where you are able to observe these patients more closely. Then you would probably do a sector for pan-retinal photocoagulation and then follow up these patients.
The one problem when we face doing in the camps, when we are screening diabetic patients, they do not give a history of laser at all to us. Second thing, what we are seeing is non-mydriatic physiological dilatation, because drops cannot be applied in the camps unless a doctor is there. That is the government initiative. So when we try to take fundus photographs, which is 45 degrees non-mydriatic, sometimes the PRP is very much in the periphery. So that doesn't come into the fundus photograph. 45 degrees, what we take, the macula and all that. Sometimes patient doesn't fixate well. So it's very difficult. And patient does not give any history. Is there any other way of giving a count or something to the patient so that the proliferative diabetic retinopathy patient is able to?
So we have to understand the limitations of doing this in a camp. We are only doing a screening for these patients. So in these patients where there has been a laser already done, I'm sure there will be a changes of the blood vessel changes will be there, like venous beading or narrowing of the vessels or changes in the vascular architecture, and then few hemorrhages would be seen. So that is an indication to ensure that this patient would need a much more detailed investigation. So it is not possible to diagnose or make a decision in the camps. So it is non-mydriatic fundus cameras is only for screening, and you cannot make a diagnosis based on that. Today, with the advent of ultra-wide field imaging, we are also realizing there are a lot of patients who present with peripheral new vessels and without much changes in the posterior pole. So this, with time, we will see that the detailed investigations will be needed for these patients. So at this point of time, it is better to pick up these patients as a screening tool when possible to identify these patients from the ICAMs or villages, wherever we are doing the screening. But this is not a diagnostic test.
Thank you, sir. Any questions from others?
So dilated screening is very important then.
Exactly.
We are promoting non-mediatic cameras, but I don't think they have.
No, the problem is government does not allow us. Government says the doctor has to be there at the campsite. If dilatation has to be done. The ophthalmologist has to be there. We can't do it with paramedical staff.
Absolutely right.
So that is the difference.
No, now we are screening in the periphery, in the areas with the trained paramedics. You are able to do it like we are doing it in the diabetology clinics. You're training their ophthalmologists, their technicians to do a dilatation of these and to manage, because the chances of dilatation causing a problem is like 1 in 20,000, or it's less than an air traffic accident happening. So we tell them also how to manage those patients in those situations. So definitely doing a dilatation that improves the diagnosis or screening or identifying high-risk patients in these areas.
Diabetic clinics are more in the urban cities, sir. The villages, when you go to the remote villages, the chances of
No,
the
I'm
patient
not talking about mobile camps when we are going in and screening. Yes, that's a challenge we
that's
still
a challenge
face.
which we have.
Yeah.
Yes, ma'am.
Dr. Aditi
Yes, sir. Good
Parasar.
evening. Yes, sir. Good evening. I have a question for sir.
Yes, Dr.
Share. Yeah.
It was an excellent presentation, sir. I have few questions to ask, sir. Sir, what is your preferred treatment modality in cases of early PDR? Would you like to take them up for PRP, or would you just like to observe them?
Depends on where the patient is coming from. If that's a very good question, it's a challenge because one, I actually had one patient who was followed up for 5 years without any treatment. 5 years after identifying an NVE in that patient. But in generally, we tend to treat these patients early on because of one, the poor compliance for these patients to follow up. But if you think that these patients can be closely followed up, I would prefer to follow these patients. And these are the patients we can now start talking about giving an intravitreal injections and if they can understand the need. So today I'm slowly starting to use that in combination with pan-retinal photocoagulation. But early on, it definitely, I would advise to go ahead with treating these patients once they have achieved a proliferative stage in these patients, because of the compliance and the chances of losing these patients to follow up.
Yes, thank you, sir. And so one more question. In patients who have like moderate NPDR with CSME, but with the ERM sitting there, so what should we do? I mean, should we keep on injecting? Because usually these patients are, what I've personally felt is that they don't give a very good response to injections. So, sir, what is your call on that?
Madam, if the patient is not responding to the treatment, multiple injections, I would definitely go in and do a vitrectomy. If we think that the ERM as seen in the OCT is the possible cause. So it's better to go ahead and do a vitrectomy and remove the ERM. That's what I would do.
So, sir, in such patients, you would like to take the patient directly up for surgery, or you would like to inject and then see the response?
No. First, do the injection if there is a definite DME in this patient, not just the ERM alone. You're not injecting for the sake of ERM. You'll be injecting if the patient has ERM with diabetic macular edema. Then you would consider doing injection. And if the patient is not responding, the EME is not subsiding with the injections, then it is an indication for going ahead with vitrectomy in these patients for ERM removal.
Thank you, sir. Thank you.
Yes, Dr. Rajvinder.
Sir, I want to ask one question.
Yes, ma'am.
This is a very good presentation. It was many things were to learn. Sir, I want to ask if the patient has a CSME and there is no tractional retinal detachment, after how many injections of anti-VEGF we should try giving steroid?
Oh, you are talking only about diabetic macular edema, not in
Yes,
case
sir,
of
yes.
PDR.
Yes.
No,
Yes.
usually we don't, we try to switch the injection depending on the OCT. If the diabetic macular edema is showing extensive subretinal fluid, then in those situations, we could switch to steroids. But again, in these, suppose the patient is a pseudophakic and he's not responding to anti-VEGF, then then you can go ahead with the steroids in these cases. Yes, ma'am.
Thank you, sir.
I have a question, sir. When you have a pre-retinal hemorrhage, boat-shaped hemorrhage, what would be your treatment?
No, you mean pre-retinal hemorrhage in the macular area is what you're
The
talking
boat-shaped
about?
hemorrhage
Yes. I mean, it depends on the
area location.
in a proliferative diabetic retinopathy, you would treat it like any other, if it is related to proliferative disease, then you would do a panretinal photocoagulation and wait for these fluids blood to observe. But in some situations, like Valsalva's maneuver, where you have a pre-retinal hemorrhage, then it's doing a laser hyaloidotomy in these patients helps to remove the blood or transmit the blood from that space into the vitreous cavity so that it gets absorbed faster. So that
Even if it's in the
visual
macula
acuity is
area, you
improved.
can do the lasers.
Yeah,
Covering
not in the case of a proliferative diabetic retinopathy. When it is associated with proliferative, either it calls for a vitrectomy depending on the extension of the vitreous hemorrhage, or you do a panretinal photocoagulation and wait for this blood to get absorbed.
Sir, I have one more question. If the patient has laser PDR, and again he come with the vitreous hemorrhage, so what should we should inject anti-VEGF, or we
You can try injecting anti-VEGF if there has been a adequate laser has been done, or even if the vitreous hemorrhage is covering the retina, then you can go ahead, inject this patient, provided ultrasound doesn't show much of a tractional component, then you can go ahead and do a intravitreal injection, wait for the blood to absorb, and then identify areas, skip areas where you can do additional laser.
Let us discuss my case. So I
Yes,
presented
sir.
in the beginning. So how do we proceed for this patient? So this is, as I said, sorry. This 37-year-old male, a lip profession, and detected only 6 months back only that he is diabetic. And after 6 months, now we can see the picture of fundus in both eyes. So
One is, it is very important to understand what is his metabolic status is like. That is very important. We have to identify, find out all his blood parameters. And as far as the eye is concerned, definitely the left eye also looks like it has got a PDR with fibrous proliferation. I would explain the situation to the patient. First, do a laser in one eye.
yes,
That is the right eye. I would observe how he responds, because many a times in these cases, especially when you do continuously laser in a deranged metabolic state, these patients within a very short period of time would develop tractional retinal detachment and would end up in your surgical table, where you would have to, the patient would have presented to you with 6/9 or 6/12 vision. You would ending up with the patient trying to give him a 3/60 or a 6/60 vision. So it is very important how these patients respond. So I usually prefer to do cautiously in these patients. After understanding his metabolic status, do a panretinal photocoagulation in one eye in 2 or 3 sittings,
yes.
and then observe this patient closely. Then once he becomes stable, then I would think of doing the laser in the second eye.
Okay. Role of injection, whether you can give the injection in the other eye?
I would not give the injection because of the tractional component, because he doesn't have macular edema at all. Doesn't look like he has any macular edema. It's purely a PDR, proliferative diabetic disease.
Yeah.
So I would rather prefer to do a peripheral panretinal photocoagulation in these patients.
Right. I think we did like that only, but we have given one injection.
In which eye, sir? Right eye or the left eye?
Right eye, but we waited for some time to the blood to clear off. What about 2 to 3 weeks we waited in the right eye. The blood has cleared up. Then we gave an injection in the right eye, and left eye we did the PRP.
No.
In 2 sittings.
So what is the reason for giving the injection, sir, instead of laser? Because following protocol, yes?
Yes.
Yeah, but how? You have to keep injecting this patient for quite some time.
Okay.
And he's a young patient. Another thing, 37 years. So the affordability, the follow-up, all that is very important for these patients. So you have to weigh all that factors in deciding on the treatment.
So this patient has to be followed up for the life, I think.
They have to. All these patients have to be followed up, sir.
All the diabetics have to be followed up lifetime. Is there any role of this anti-VEGF in subhyaloid or pre-retinal hemorrhage?
Heavy PFCL. So, which one are you asking, sir?
So is there any role of anti-VEGF in subretinal hemorrhage or pre-hyaloid hemorrhage?
Anti-VEGF in subhyaloid hemorrhage or pre-retinal hemorrhage?
Yes.
In proliferative disease?
Yes, yes.
Not really. No, there is no direct, cause and injection and then the effect. It's more of anti-VEGF is only going to reduce the VEGF component there. So
that is the reason we are given to clearing up hemorrhage in the retina. The pre-retinal, sometimes we see that the retinal hemorrhage clears fast with the injections. I don't know what the mechanism.
Pre-retinal doesn't. The VEGF, the vitreous component gets absorbed because you don't see any further bleeding due to the reduced anti-VEGF.
Sir, it means we can give the option to the patients for PRP or anti-VEGF. If patient can afford, we should inject anti-VEGF.
You can, if you're sure that patient is going to be following up with you for the next 3 or 4 years, almost on a monthly or 2 monthly basis. Yes. If it's an educated patient and you think, they would follow up, then these are the patients you can.
I have one patient with the laser PDR, and whenever he has vitreous hemorrhage, he usually come for injection. Ki unka dikhna kat gaya, give me injection.
Yes.
So,
Yeah, those are okay. Those are fine with the. But you still would like to identify if there is still a component of new vessels elsewhere in these patients. Either do a fluorescein if these patients are getting a recurrent bleeding. It would be good to find if there is anything in the periphery that is causing, the blood to come again.
yes, sir.
I have a question, sir. Once you've done PRP, patient develops a dense vitreous hemorrhage. How long would you wait to do vitrectomy? What would be the indication for vitrectomy, or would you wait even there is recurrent bleeding?
No, if the patient has got bleeding, a dense vitreous hemorrhage, which is not resolving with a month or 2 post your PRP, and there is traction, if it's anywhere present, I would consider going ahead with the vitrectomy, removing the blood and the tractional components, and adding additional laser in those patients.
There's no tractional component, just that when you're doing an
Even
ultrasound.
if it's a simple vitreous hemorrhage, you can definitely do if it is not resolving. So what's happening in those patients is, like, if it is not resolving, one, their metabolic status is also not good. And the vitreous, even though the blood is getting absorbed, there's a rebleed that is continuously happening in these patients somewhere. So it would be better to do a vitrectomy in these patients.
Then
Yes,
2
sir,
months. Wait for 2 months and then do it.
Yeah.
Yes.
Yes, sir. Dr. Sukumar Sarkar, sir, your question. I would like to say something. Welcome. Welcome, Professor Sukumar Sarkar. Sir, yes, sir. Please proceed. Dr. Sarkar.
No.
He can't hear us. He can't hear us.
Any other questions?
So when we are planning for pan-retinal photocoagulation in 3 sittings, how should we plan? We can do all 3 days, first, second, third day, or we should keep a gap in between?
Usually we prefer a week's gap in between these patients, like you do, and then you start with laser inferiorly first, because even if you have a vitreous hemorrhage post your laser, then you would have definitely treated and the blood would be settling down in the bottom. So we prefer to do it in the inferior half first, and then usually with at least a week in between each sitting.
But sir, in the Ayushman, like they give for panretinal photocoagulation, but we can admit the patient for 3 days. So we can keep on doing on 3 subsequent days.
We have been doing that, but there is the risk of the traction or whatever happening in these patients are a little higher.
Macular edema also.
Yeah, macular edema also is higher in these patients. Whatever the Western literature may say, our Indian patients, especially, the metabolic status, which is so poor in these patients, I prefer that we don't do it almost sequentially every day.
Okay, sir.
So if there are no further questions, sir.
Sir, should we start with the
Dr.
polls now?
Patnaik to summarize and leave.
And there is one question. Somebody is asking one question.
Sir, should we start with the polling questions?
Yeah, please proceed.
Okay, yes.
Okay, sir. Requesting all the participants to please fill up the questions on your screen. There are 5 questions.
How do you answer this? Just choose one.
Yes, sir. Then we'll discuss one by one. Now the participants are just filling up the answers and then we can discuss.
Sir, I have one last question. Sir.
Yes, ma'am.
Sir, what is your advice in treating patients, especially who are young patients with PDR and with FPs? What is your advice on doing PRP? I mean, what are the things that we should be more careful about?
These are the patients who have an aggressive disease or aggressive proliferation happens in these patients. So usually it is better to be treating aggressively on these patients with panretinal early on. And the more important, again, I keep stressing on the metabolic status of these patients. That's also very important in these patients. So these patients should be treated early on once you reach the proliferative disease, because they have a very aggressive traction that will happen in these patients.
So such patients, should we laser up to the aura, or should we try to save some part of the retina?
No, you should try as much to the periphery as possible.
Even if the patient is young?
Yes. To the periphery.
All right, sir.
Yeah.
Thank you, sir.
Sir, I'm ending the poll now.
Yes.
Sir, we can now discuss one by one. You can see it on your screen.
Yeah. So should I do that?
Yes, sir, you can just answer the
Yeah,
questions and
okay.
just discuss.
So which is included in the high risk, and what are the high risk characteristics in patients with proliferative disease? That is, we mentioned neovascularization of the disc, which is more than 1/3 or 1/2 of the disc, 1/4 of the disc diameter, or NVD. And in this, as you see, all the three of them are correct. So all is the answer, which is correct in this case. So we need to understand this high risk characteristics more important in deciding on the pan-retinal photocoagulation. But there are other factors which continue to play, as we've discussed, about the metabolic status, about the follow-up of these patients, whether these patients would follow up. Sometimes you would do, even in the case of a severe NPDR, you would probably do a patient pan-retinal photocoagulation in those cases. Second question, which study compares pan-retinal photocoagulation versus the injection of the ranibizumab? Of course, it is protocol yes. As you all know, there are very few studies that took proliferative disease as a factor for anti-VEGF injections. And one of them is the most important is the protocol yes by the Diabetic Retinopathy Clinical Research Network, the DRCR network. The third question, which is not an indication for vitrectomy in the presence of proliferative diabetic retinopathy. Of course, persistent vitreous hemorrhage, macular traction RD with neovascular glaucoma, all these are indicators. While central cholesterol plaques with DME, you're not going to do a vitrectomy in these patients in a case of proliferative diabetic retinopathy. So NVD is depicted by the standard photograph, as I showed you. It's the standard 10A photograph, which I showed you in one of the slides, is the right answer. So which study described the beneficial role of pan-retinal photocoagulation? Way back, the first multicentric study, which is the diabetic retinopathy study, gave an answer to this. This was not part of my presentation, but I'm glad many people did answer this. Thank you. Thank you, Shweta. That's about it.
Thank you, sir. Thank you very much for this excellent presentation. With your vast knowledge in managing diabetic retinopathy for so many years, still you made it so simplified. Now, my advice on this situation is we have to try, all of us, so not to let people go to this stage where things like injections or VR surgeries will be required for the population. So that is the way. If we can do that, then we can prevent diabetic blindness in future. So thank you, sir. Thank you very much.
Thank you. Thank you, sir. Thank
Thank
you all. So, thank you,
You are muted.
Subhuti
You are
sir. Thank
muted,
you,
sir.
Shweta.
Thank you all for attending this nice webinar, and we
Thank you.
welcome you again, once again, for our last webinar on 20th of this month, Wednesday, 8 p.m.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.
Bye. Good night.